Thanks AOS for giving me the opportunity to speak on this topic. This is a common topic, but we have done extensive work since last 25 years on this topic. I don't have any financial disclosures. As you know that diabetic macular edema, there are certain facts. It is a chronic, progressive and difficult to manage. The systemic factors plays more role than the local factors, that is ocular factors, more prevalent than any other diabetic complications of the eye, that is TRD and vitreous hemorrhage. There is always and loss of quality of the vision, and that too in a executive patients, which is a common cause of frustration. And being a refractory, it is causes the tension to the both the patient as well as the doctors. The basic pathology is not known, but it is known that it is a multifactorial and it is a progressive. It is in response to the raised intracellular sugar hyperglycemia, which causes the release of free radicals, PKC and AGE, which in turns causes the hypoxia, ischemia, that induces inflammation, releases anti-VEGFs, and there is alteration in the vitreomacular interface. So in few studies it is found that it is a chronic inflammation and which causes the breakdown of the blood retinal barrier, capillary occlusions and tissue ischemia. So in all, we know that diabetic macular edema is a multifactorial etiology. It is a multimodal imaging is required and multimodal therapy is also required. Previously, we used to do the classify it into the clinical as well as angiographic classification like focal, diffuse, ischemic maculopathy as well as mixed and cystoid type of maculopathy. The DME management and its role of OCT has been changed the world of retina surgeons. Before OCT and after OCT, the management has been changed. We know that there are several types of presentations on clinical pictures we can get because of OCT, before treatment, after treatment and response to the treatment, and why there is no response to the treatment. That is possible because of the OCT. So what are the normal treatment modalities which we are using is lasers, anti-VEGFs and steroids as well as the surgeries. The lasers are not suitable in all cases, we will see that, and most of the times the systemic factors plays a role. Patients hyperglycemia, patients hypercholesteremia as well as the renal status and other systemic factors also plays role, so it won't respond well to the treatment. So when we come across with the diabetic maculopathy or diabetic macular edema, then what is in our hand is that we should treat with the anti-VEGFs, we should treat with the lasers, with the yellow micropulse lasers also available, Ozurdex, IVTH, as well as if it is associated with EP retinal membranes and reluctant, then we can consider surgery, or in all together we may have to consider combinations of one after another, or if one is not working, then another. Then in such reluctant cases or long-standing cases, there are several questions are asked by the patients, frequently asked. Is the laser redundant nowadays in diabetic maculopathy? What is the end point of the anti-VEGF? Will laser add reduce anti-VEGF therapy? What is the ideal situation for steroids? How does one reduce surgical or treatment course? Then we know that this is the ischemic maculopathy which can be diagnosed with the angiography as well as the OCT angiography nowadays. That is one of the cause. Apart from that, if peripheral ischemia is there and if you have not treated properly the periphery in a PDR cases also, that can cause also the maculopathy. That is to be noted down in ultra-wide field angiography. Another thing is the focal maculopathy, which we know that the succinate hemorrhages, succinate exudates are there around the microaneurysm. These can be treated well with the laser therapy is enough, and we know that the laser works here. But there are certain limitations to the laser. If it, the microaneurysms or leaks are in the papillomacular bundle, the lasers you cannot fire more and patient will lose the vision. So, and if it is a diffuse type of maculopathy, obviously the systemic factors plays a role, and one has to take care of the hyperlipidemia as well as the renal components and sugar components, and then only it works. And in such situations, what is multimodal is that first you have to give the anti-VEGFs several times and then do the lasers, and again you have to keep on injecting the things till the systemic factors come under control. Another things are there. We know that the anti-VEGFs works very well. Within hours or within few days, you get the good results after anti-VEGFs. So whatever the anti-VEGFs you are using, it works if it has to work, because most of the diabetic macular edema is because of the raised VEGF component in the intraocular component, VEGF component. And you can see there are several pictures which are pre and post anti-VEGFs. But despite of all these, there are certain cases which do not respond properly or marginally they respond. In such cases, what to do? Still we have to keep on doing. There are certain cases here, I am seeing that he has received almost 16 ranibizumab, but it was not responding well. Then we have tried brolucizumab in this case off label, and after 3 injections you can see that it has come down to the normalcy. We don't know what is going to happen, and in these cases particularly it is very important that the patient keeps on coming to you years together. So it's your responsibility and treatment policy making which is suitable for him, and advise that treatment modality. That is how it is a multimodal treatment according to the patients. If it is associated with PDR, then obviously the anti-VEGF is the first line of treatment. If it is associated with renal as well as hypertension, then obviously anti-VEGF first and then lasers. There are certain situations of maculopathy where the hard exudate crystals are subfoveal. Then what to do? Still, as per DRCR net classification or the guidelines, we keep on treating, and you can see in the right side image, the patient has responded and hard exudate crystals have gone, and the vision also come back to little bit better than what it was started. There are certain cases where there is a mixed type of retinopathy where you have to keep on trying all the types of modalities, and one fine day you will get the results. Another modality is the steroids. Steroids, you know that they are pan anti-VEGF, as well as apart from the VEGF, it also acts against the various inflammatory modulators. In those cases, we have to see for the biological indicators, or that is what is OCT markers, where the intraretinal high reflective things are there, then subretinal fluid is there. Obviously, the steroid is the first choice, and you can see that after steroids also you get the resolution of the edema. If these are the cases where it was a reluctant. If it is a post-operative or this is a pseudophakic cystoid macular edema in diabetic, obviously IVT or PST also can work. Here you can see that with the biomarker studies you can think of giving the steroids. And there are certain situations where the ERMs are there. ERMs are there with diabetic macular edema, then obviously surgery is the choice. You can see the pre-operative and post-operative pictures, and they work very well. And whatever the treatment, this is what I have observed, sir, in last 20 years or 22 years of the practice. Most of the time, because of multifactorial and multi-etiological things, you treat it, the edema goes again and again, rebound edema is the rule most of the times, and that is to be taken, and it should be considered and counseled very well with the patients. With the current modalities available, new molecules coming and their durability, you have to keep on treating. And but one thing is sure, that with the systemic control as well as the consistency in the treatment, whatever the modalities, whether it is a combination or one molecule you are giving regularly, it is helpful. Otherwise, it is non-preventable, or there is no complete cure. Only thing that you can early detect and treat it properly. Thank you very much.
Thank you, Dr. Manoj.
Thank you, Manoj, for this entire talk. But judicious use, you know, how to start, which patient to start anti-VEGF, which patient to start steroid, if at all, and when to shift. So these are the key concerns.
These are key. And for that, I will say that we should not depend only on the OCT. Always we should remember that what classification we have learned in our PG days also. That also works. Focal maculopathy, ischemic maculopathy, diffuse maculopathy, mixed type of that. If you know that what is the ocular manifestations, as well as you just
no, what thing
segregate.
Is that something to take back is, all of us I think agree that we start on anti-VEGF agents.
Yes, anti-VEGF is
okay.
the
And out of the anti-VEGF agents, by and large, aflibercept scores over the others.
Yes, aflibercept.
Nowadays
we know that, and the number of injections also has been reduced because of the duration of action of
the
aflibercept.
second point is when to shift, if at all you have to shift.
Yes.
So do you consider shifting after 2, 3, 4, 6?
Yes, we have to shift, and we have noted that even shifting from one molecule to another also helps, and shifting from anti-VEGF to steroid also helps. Particularly, you have to judiciously, as you say, that you have to see that why he is not responding, because of systemic factors or local factors. If it is systemic factors are not under control, then obviously whatever you give, it will delay the response, or a marginally response will be there. In that cases, as you ask, 4-5 injection we can try, again reevaluate the case, again ask them that he is spending so much of money and not taking care of the systemic factors, then there is no point in continuing that molecule as well as the same treatment. In that situation, strictly warn the patient, because whole onus is going to come. You at the end of the treatment, he is going to come with I have taken 4 injections, 5 injections. He keeps on counting.
Thank you, sir.
Okay.
Thank you.
Thank you.
Thank you very much, sir. Thank you.
Thank you for a wonderful compilation.